Good afternoon, everyone. My name is Bridget Burns. I am the Senior PAR Specialist at the American Thoracic Society, the ATS. Welcome to the 9th installment in the 2018 Lung Disease Week at the ATS series and to Pulmonary Fibrosis Week at the ATS, which runs this week from August 19th until the 25th. The webinar today is entitled Pulmonary Fibrosis, Myths and Misconceptions Debunked, and is being presented as part of the Pulmonary Fibrosis Week educational programming. This program is a joint partnership between the American Thoracic Society and the Pulmonary Fibrosis Foundation. First, we need to inform you that the subject matter discussed here today is designed for educational purposes only. Therefore, you should not rely on this information as a substitute for personal medical attention, direct medical care, or diagnosis from a physician. If you are in need of immediate medical help today, please consult your family's healthcare provider right away. Do not wait for a response from our members, staffs, or partners. A little bit of housekeeping information. If you are properly logged into the webinar, you should be seeing my desktop and hearing my voice via your computer speakers. Some people may be dialing in with their telephone and should have been provided with a toll-free number, access code, and an audio PIN. If you are dialing in with your phone, please turn down or turn off completely your computer speakers to avoid audio feedback. After the presentation, you may ask questions by clicking the question sign icon and type a message into the chat box that pops up. The message comes to me and I'll relay the question to the presenter. First, I would like to acknowledge our partner, Ms. Jennifer Medford, Director of Strategic Partnerships at the Pulmonary Fibrosis Foundation and current member of the ATS Public Advisory Roundtable PAR. Next, I'd like to welcome our featured speaker today, Dr. David Lederer. Dr. Lederer, would you like to begin?
Sure. Thank you, Bridget. I'm very excited to be here. Thank you for letting me be a part of this. My name, again, is David Lederer. I'm a pulmonologist and specialist in pulmonary fibrosis. I work at Columbia University in New York, and I'm also a senior medical advisor for the Pulmonary Fibrosis Foundation. So very excited to be here. As Bridget told you, the title of today's webinar is Pulmonary Fibrosis Myths and Misconceptions Debunked, and I've put this together with the team in a way that really tries to get at many of the issues that I find questions my patients have in the office, while at the same time I think I'm going to also throw quite a bit of information at you. As Bridget mentioned, this is informational. I am not going to make any medical recommendations or give you medical advice. Anything you hear from me, I would encourage you to bring it back to your doctor and see if it applies to you. You should not make any changes to anything about your health or your medical regimen based on any of the information you hear today. I'll also discuss some off-label use of medications. Off-label means that a treatment is used for a reason other than the FDA-approved reason, which we as physicians do all the time, but I just wanted you to caution you about that, and that'll come back in about 20 minutes. I'll mention that again. So before we get into the first myth, I'd like to define a few terms. I find that the terminology in this family of diseases is confusing, not just for patients, but also for doctors and other healthcare providers. So let me define a few of these. The first one is interstitial lung disease. And that's not one disease. As I'll show you in a slide, it's actually many diseases all lumped together in a family. We abbreviate it ILD, and it refers to inflammation or scarring in the lungs that's not due to an infection. And it's also not any kind of cancer at all. That would be obviously a different type of disease. And then you may also hear the word fibrosis a lot. And that word simply means scar tissue. And we, for example, if you have a scar from surgery on your skin, I as a doctor probably wouldn't call that fibrosis, but the fibrosis that occurs in the lungs or other organs in a disease, we would call that scar tissue fibrosis. And then, of course, the term pulmonary fibrosis, I think all of you have heard of, sometimes abbreviated PF, and that really just refers to any kind of interstitial lung disease when scarring is present. And in my experience, most of the interstitial lung diseases have scarring, and doctors will often use the terms interstitial lung disease and pulmonary fibrosis interchangeably and may even go back and forth. And you'll notice throughout today's webinar, I will kind of go back and forth between those terms. You can just think of them for today as pretty much the same family of diseases. So let's turn to the first myth. The first myth is, if no cause is found for someone's interstitial lung disease, then their diagnosis is idiopathic pulmonary fibrosis, or IPF. And this myth addresses the kind of fourth terminology, or idiopathic pulmonary fibrosis, that becomes very confusing, right? We have interstitial lung disease, we have fibrosis, we have pulmonary fibrosis, and now we have idiopathic pulmonary fibrosis. So how can I understand all of that in a simple way? And so I like to use this picture. If any of my patients are on here, I know they've seen this. This is an image that appears in the Pulmonary Fibrosis Information Guide. It was put together by the Pulmonary Fibrosis Foundation. You can even go to the Pulmonary Fibrosis Foundation's website, which is pulmonaryfibrosis.org, and download this guide or even order it through the Patient Communication Center, which is pcc@pulmonaryfibrosis.org, and they'll send it to you in the mail. So let's look at this picture here. Here's an oval. That oval, the big oval there, labeled as all lung diseases. Let's imagine that that oval encompasses every lung disease we know about. So within that oval there would be COPD, there would be asthma, there would be cystic fibrosis. We could put bacterial pneumonia in there, any disease that affects the lungs. And on the left we have the smaller blue circle labeled interstitial lung diseases. Remember, that's the big family of lung diseases. And there are over 200 different types of ILD. And as I mentioned earlier, those that have scar tissue we would refer to as pulmonary fibrosis. So within this interstitial lung disease oval, we could actually draw many little circles representing each individual type of interstitial lung disease. And one of them, just one of those circles, would be idiopathic pulmonary fibrosis, which means that there are many other kinds of interstitial lung disease that are not idiopathic pulmonary fibrosis. The word idiopathic means of unknown cause, and about half of all of the patients who come into my office have an interstitial lung disease of unknown cause. But again, IPF is only one of those idiopathic ILDs or ILDs of unknown cause. And here's a list of just 6 different interstitial lung diseases of unknown cause. And the first one there with the arrow, again, is IPF. But I've also listed idiopathic nonspecific interstitial pneumonia, respiratory bronchiolitis associated interstitial lung disease, desquamative interstitial pneumonia, cryptogenic organizing pneumonia, sarcoidosis, and many others would be on this list. These are just a few. So it is, I have to admit, and I know it is confusing because the word idiopathic means of unknown cause, and we have idiopathic pulmonary fibrosis, but that's just one kind. So I know it's confusing. I hope these past few slides have clarified that a little bit. I hope that that picture with the different ovals might be helpful. So IPF is just one interstitial lung disease of unknown cause. So that brings us to myth number 2, which is that no one knows what causes interstitial lung disease. And so that's not true. If you remember, I said that half of the patients who come to my office who have interstitial lung disease have it for unknown reasons, but that means the other half have disease for known reasons. And this table, which also comes from the Pulmonary Fibrosis Information Guide, lists the 5 major categories of interstitial lung disease of known cause. So the first one on that list there is drug-induced, and what we mean there is medication-induced. And there are a number of medications that are known to injure or inflame or cause scarring in the lungs. A few examples listed here are amiodarone, which is a medication used to treat certain heart arrhythmias like atrial fibrillation. Nitrofurantoin, which is a commonly used antibiotic that treats urinary tract infections. Certain forms of chemotherapy and other medications like methotrexate can also affect the lungs. The second category are radiation-induced lung diseases, and this is usually fairly apparent because someone has had radiation therapy to the chest. In some cases, these are minor little changes that are of no concern, but some people can develop severe forms of pulmonary fibrosis if they've had a lot of radiation to the chest in the past, treating cancer. The third category there, which is labeled environmental, is quite common among people who have pulmonary fibrosis. The medical term for this is hypersensitivity pneumonitis, which we abbreviate HP, so I may refer to it as HP. And hypersensitivity means the lungs are too sensitive to something that's being breathed in. And the most common cause of this in my neck of the woods, meaning the northeastern United States, is exposure to airborne mold, either in the house, in the workplace, or some other indoor environment that someone spends a lot of time in. And with slow, long-term exposure to mold, that can cause inflammation and scarring in the lungs. And when the scarring occurs, we also use the word chronic. So you may hear the term chronic hypersensitivity pneumonitis. And that condition can look a lot like any other kind of pulmonary fibrosis, including idiopathic pulmonary fibrosis. So as I mentioned, mold exposure in the home or workplace. And so as a doctor with a patient in front of me, when I'm trying to figure out what kind of lung disease they have, I will often ask them, I will always ask them questions about possible mold exposure. And mold is usually found in areas that have standing water or water damage. So I'll ask about prior flooding in the home, pipes leaking, standing water such as a hot tub or humidifier, and other sources of potential mold in the home. Another, maybe less common trigger can be exposure to animals, and really the main animal are birds. And these are birds, usually large birds that live indoors. Someone might be taking care of one or more, say, cockatiels or parrots or other birds in the home. And chronic exposure to some protein the bird is shedding can lead to inflammation and scarring in the lungs. This can also occur with birds in cages or coops outdoors, like pigeons. And in one family, I saw two family members who had it from exposure to chickens they were taking care of on their farm. And there have been lots of other descriptions of different things that can cause hypersensitivity pneumonitis. So, you know, when you are being diagnosed, your doctor will ask you a lot about these things. Then the fourth category here is called autoimmune or connective tissue disease related interstitial lung disease. The word autoimmune means that the body's immune system is attacking tissues and organs in the body, causing inflammation and scarring. A few examples of autoimmune diseases include rheumatoid arthritis, which is different than the run-of-the-mill arthritis that many of us get, which we refer to as osteoarthritis. But rheumatoid arthritis is autoimmune. So is a condition called scleroderma, another one called dermatomyositis, and there are certainly many others. The three that I mentioned in particular can be associated with the development of interstitial lung disease. And so again, with a patient in my office, I will often ask them questions about their joints and their skin and other symptoms that might result from autoimmune disease, and I'll carefully examine them to look for evidence of autoimmune diseases. And blood tests are very important here and can help point us towards one or another autoimmune condition. And then finally, the bottom category, occupational. I'm sure that most or almost all of you have heard about asbestos, and which causes a condition called asbestosis, which is pulmonary fibrosis from inhalation of asbestos. And you've probably heard of black lung, which has a medical name of coal workers pneumoconiosis. The word pneumoconiosis is a medical term that refers to any form of pulmonary fibrosis due to an occupational exposure. And there are many others, so I'll also ask my patients what kind of work they've done in their life and whether they've had certain exposures. And so you can see that just by talking to your doctor and your doctor asking you the right questions and examining you and doing some blood tests, that we can often figure out why you have interstitial lung disease. Again, in my case, I think probably in about half of my patients, I can figure out why they had it, and in about half, I can't. Now here's something interesting, which is that even when we call the disease idiopathic, we've actually begun to identify certain risk factors for idiopathic interstitial lung diseases. And of course, as I mentioned earlier, there are many different kinds, but we found that as people age, their lungs are more susceptible to developing scar tissue. And of course, people who have certain genes might be at increased risk for developing scar tissue in the lungs. Smoking certainly increases the risk for some forms of interstitial lung disease. Interestingly, autoimmunity, and I mentioned the word autoimmune before, but it turns out there are people who have some kind of autoimmune response, meaning their body might be attacking their lung and causing inflammation and scarring, but they actually don't have an autoimmune disease like rheumatoid arthritis or scleroderma that I mentioned earlier. So sometimes just having some autoimmunity for reasons we don't understand and for which we can't put a name on, that may be contributing to lung disease in some people. We've also found that people with severe acid reflux, certain other occupational exposures, air pollution, and even obstructive sleep apnea have all been linked to interstitial lung diseases. We don't know that these things are causing interstitial lung disease, and all of these are under a lot of research and investigation right now, trying to figure out which of these are important and which of these we could potentially target as treatments or even preventative therapies for pulmonary fibrosis. Let's move to myth number 3. It's that a lung biopsy is required to diagnose interstitial lung disease or idiopathic pulmonary fibrosis. And it's only a myth because it's not always true. That is, sometimes we need it, but most often we don't. And so there are a few circumstances where a biopsy is not performed. Before I tell you that, I have to tell you 2 really important things. So the first is the way the doctors figure out that interstitial lung disease is in your lungs is by using a CAT scan. And that's a test, kind of like a fancy chest x-ray, where we get to look at the lungs in detail. So we can visually, these days on a computer screen, see the inside of the lungs and see that interstitial lung disease is present. And then, we'll kind of ask you those questions about the things you see on the screen, medications, radiation, etc. And between the appearance of the disease on the CAT scan and asking you these questions, we often can figure out the diagnosis, not just that you have interstitial lung disease, but which kind of interstitial lung disease. And then in that case, there's no need for a biopsy. A biopsy is when we take, this is the second thing, a biopsy is when we take a small piece of lung tissue and look at it under the microscope, and it's this is on the next slide, but the visual pattern of inflammation and scarring on that biopsy that tells us which kind of interstitial lung disease you have. But we do try to do everything we can to avoid doing a biopsy because there is some risk associated with that procedure. And in some cases, even when we think a biopsy could be helpful, if we think it might be too risky for you because of your specific medical condition or other medical problems, then biopsy would not be done and we'd be left with some degree of uncertainty, which is probably better than taking risk. But as I said, in some cases it is very helpful, but there's no single right decision. That is, it isn't that everyone should or shouldn't do it. It really has to be individualized to each person. As I mentioned, it's the visual pattern of scarring and inflammation in the lung that we see under a microscope that can be helpful. Sometimes it tells us the cause of the condition. Often it'll tell us the name of the condition, but the most important thing is, does it help us figure out how to treat you? That is, if we see one certain pattern under the microscope, we might give you medication A, and if we see a different pattern under the microscope, we might give you medication B or a different pattern, and we might say, you know what, the best thing is not to take medication because we don't have medication that's going to help this particular condition, and if we don't treat you, we can avoid all the side effects of the medication. And just so you know, there's about, I don't know, 1 out of 10 times that we do the biopsy and it really doesn't help us any more than if we didn't do the biopsy. That is, it just doesn't give us enough information sometimes. But we do factor that in. You know, we say, well, how likely is it that this is going to, a biopsy is going to help us improve the treatment strategy for this patient, and we factor that in. So let's move to myth number 4. There are no effective treatments for pulmonary fibrosis. This is absolutely not true, but I hear this all the time from doctors, from patients, from other people, that there's nothing to do for this condition or for this family of conditions. And so it's my hope that this very, very full slide with lots of words might convince you that there's actually a lot of things we can do for people living with pulmonary fibrosis. There's a whole list here of things that can help you feel better, including oxygen, pulmonary rehabilitation, which I'll come back to later, medications, which I'll also come back to, lung transplantation, quitting smoking, and if you do smoke or use any tobacco or nicotine products, please go see your doctor to talk about quitting. Achieving a healthy weight, eating a healthy diet, joining a support group, and in particular, joining a support group, some of you may not be involved in a support group but may want to be involved in a support group. If you'd like to find one near you, you can go to the Pulmonary Fibrosis Foundation's website, which again is pulmonaryfibrosis.org. Click on Find Medical Care, and you can search for a support group near you. And the PFF supports, honestly don't know, dozens of support groups around the country and even a few outside the U.S. So there are also things that can slow down your disease, slow down progression. And that's what we always worry about with scar tissue, that it can build up, and meaning that would be progression of your disease. But as I'll mention in a little bit, some medications can slow down progression. A lung transplant, which can be kind of transformative, can improve your lung function. And then, as you can see here on the right, there are actually many things that also can keep you healthy. And I won't go through that whole list, except to mention at the bottom, vaccination, which is really important for influenza, which is flu, but also for pneumonia. Talk to your doctor to see if pneumonia vaccinations are appropriate. And washing your hands and using Purell, avoiding infections. If you have lung disease and you get an infection on top of lung disease, that could be very serious. So a lot of things we can do. It's not nothing. So let me mention some of these medications. This slide refers only to idiopathic pulmonary fibrosis. The next slide will refer to other forms of interstitial lung disease. So I'll mention 2 medications that are approved by the FDA in the United States to treat idiopathic pulmonary fibrosis. These drugs are also approved in many other countries around the world to treat IPF. The drugs are pirfenidone and nintedanib. You may know them by their brand names, which are Esbriet and Ofev. And these drugs each slow progression of the disease by 50%, which means it slows the buildup of scar tissue in the lungs by half over the course of time. Now, they don't reduce the scar tissue that's already there. That is, we don't expect these medications to really make you feel better in a day or a week or a month, and we don't expect them to make your lung function numbers improve or to make your oxygen requirements go down. But in the long term, people tend to be healthier and better off for a longer period of time if they do take the medication compared to if they didn't take the medication. And both drugs are recommended for use by a clinical practice guideline put out by the American Thoracic Society that was published in 2015. The side effects of the drugs differ. Pirfenidone tends to cause upset stomach, also loss of appetite, maybe nausea, and can cause a rash, particularly in response to the sun. So people who take pirfenidone will often get very specific instructions about how to take it and how to minimize side effects. Nintedanib tends to cause diarrhea. About 50 or 60% of people who take nintedanib will have some degree of diarrhea or loose or frequent stools. That can also be managed by taking other medications, over-the-counter medications. Occasionally, nintedanib can cause other side effects. Both drugs have certain precautions that need to be adhered to, certain monitoring and drug interactions, and I'm not going to go into all of those things, but instead ask you to talk to your healthcare provider about the risks and benefits of these medications and how they might or might not be used for you. But I also should mention that as of today, and this is August 2018, neither of these drugs are approved by the FDA to treat other forms of interstitial lung disease. They're only approved to treat idiopathic pulmonary fibrosis. Now, at the beginning of the talk, I mentioned off-label use of medications, and that means that these are medications that are approved by the FDA, but they're being used by doctors for reasons other than the reason they were FDA approved. And we do this all the time. In fact, most of the time when doctors prescribe medications, they're prescribing them for reasons other than the reason the FDA approved them, because they've been shown to work for these other conditions without going back to the FDA to ask the FDA to approve it for those other conditions. Anyway, for people who have interstitial lung disease where there is inflammation in the lungs, here is a list of some of the medications we might use to treat that inflammation. Many of you have probably heard of steroids. The predominant one that's used in the United States is prednisone, and that's taken as a pill by mouth, and it weakens the immune system. All of these medications weaken the immune system, and therefore it can decrease inflammation in the lungs. Prednisone can have many side effects. I won't go into all of them. We also sometimes use a drug called mycophenolate mofetil. The brand name is Cellcept. We also sometimes use azathioprine. The brand name is Imuran. Another one is rituximab, and the brand name is Rituxan. And finally, cyclophosphamide, also called Cytoxan. And these drugs are used in different situations in different ways for different patients. It really needs to be individualized to each person. So again, I'd refer you back to your doctor or other healthcare provider to discuss the details and risks and benefits of those medications. Myth number 5, I've heard this a lot. This is that oxygen is addictive. And it is a myth. It's not truly addictive, but I know why people think it's addictive, and I'm going to talk you through it a little bit. The truth is everyone, in a sense, is addicted to oxygen. It's 20% of the air we breathe, and we all need it, right? So in a sense, we're all addicted. I don't mean to make light of that. Now, in interstitial lung disease, the scarring and inflammation can make it difficult for oxygen to get into the bloodstream. It actually even makes it hard to get it into the lungs itself because the lungs are stiff. So when you take a breath in, you can't get oxygen into those stiff areas. And then low oxygen levels cause the lung to work very hard to try to maintain normal oxygen levels. It turns out the lung doesn't just sit there and let the oxygen seep into the bloodstream. The lung can actually act. It actually can work hard to redirect blood flow to healthy areas to pick up the oxygen. But when the lung is working hard like that, it squeezes down on the blood vessels in the lung. And when the blood vessels in the lung squeeze down, that means the heart, which is pumping blood through those blood vessels, has to work really hard to get the blood through there. And that means that low oxygen levels put stress and strain on the heart. And that alone is, in my mind, really enough reason to think about using oxygen if you need it. Here's the thing. Once you start using oxygen, the lung doesn't have to work so hard. It can relax, which is good, because then there's less strain and stress on the heart. But it also means that you need that oxygen to push the oxygen into the bloodstream, because the lung is now kind of lazy, I guess you could say. So if you've been using oxygen and the lung isn't working hard anymore, and then you take the oxygen off, your oxygen levels can actually go much lower than they used to be. And that's why people feel they're addicted, because once they start using it, their oxygen levels are lower when they're not using it. But the truth is, your oxygen levels drop because it's healthy to have a relaxed lung that's not working so hard. So once you start using oxygen, yes, you do continue to need it. You need it. It's not that you're addicted, it's that your body needs it to function well and to not put stress and strain on your heart. I know that was a little bit of an awkward explanation, but I hope the bottom line that you understand is that oxygen is healthy because it allows you to get oxygen to all of your organs. It also can help prevent breathlessness when you're active. But I'm always thinking about how much stress and strain low oxygen levels put on the heart, and you need to wear, if your doctor recommends it, you need to use that oxygen to keep your heart healthy. Very important. Let's move to myth number 6. And this one is, again, one that I hear very frequently, is that I only have 3 years or I only have 5 years to live because I have pulmonary fibrosis. So I'm going to try to show you how this is really not true. The first thing is that this number that you hear about on the internet, or that you might have been told by a doctor or someone else with the disease, is that the average is 3 to 5 years. And when we talk about averages in this setting, what we mean is that half of people live longer than that. So it's not that 100% of people die in 3 years. It's that 50% live longer than 3 to 5 years. But there's more. This average only applies to IPF, and many other forms of interstitial lung disease may have a better average prognosis. And then even more, this number also only applies when there are symptoms present, and we're picking up this disease earlier and earlier. So someone who has very early disease, very mild disease, they may have many years before this number even begins to apply to them. And then one more thing is that this is really an old number. This number first showed up in, I think, 2001, and that means it referred to people in the 1990s. So we have new medications, we have better ways to manage people, and we have ways of avoiding harmful things. There are some things that are harmful in pulmonary fibrosis. So nowadays, the average for people with or without IPF is probably much better than this number. Now, there's one more thing. If you're a I don't know how many of you are my patients, but if you've come to see me and we've had a discussion about your prognosis, what I probably said is I have no idea how long you're going to live, because no one knows. And if I did know, it would kind of be magical. The idea that doctors can give you an accurate prognosis is usually, it's just not true. I think there are a few exceptions when someone is very, very healthy or very, very sick, but in between it's really hard. So I've had people who who without a lung transplant, who've been alive for more than 10 years with different forms of pulmonary fibrosis, and I've had people who have died within a week of seeing me in the office because they showed up very, very sick. And then I've had people who were doing well and all of a sudden got sick for reasons that we didn't understand. And everyone has a different course of this disease. Some people are very stable for years. Some people progress more rapidly than I'd like. And there's a typo here. It should say uncertainty, not uncertainly. Uncertainty, I think, and this is, you may not agree, but I think it's a good thing. Meaning, although I can't make any guarantees about the short term, there is and should be, for many of you, some hope that things may remain you may remain relatively healthy and well for some time. And of course, everyone, I'm sure, on this webinar is living with a different stage or state of the disease. So I can't address that to you specifically, but I do think having some uncertainty is better than saying I'm certain that it's terrible, because it's not, I'm never certain that it's terrible. But also uncertainty is a hard thing. It's a hard thing to live with. not knowing what's going to happen or when it's going to happen. But I encourage you to think about what's happening today and hope for the best and plan for the worst and work with your doctor and your healthcare team and see how things go. And it may surprise you. Okay, let's move to lung transplantation. Similar kind of myth that lung transplantation will give me 5 years. And that's also not exactly true for very similar reasons. So first, the average it's not 5 years. Nowadays, it's about 6 years. And for younger folks, it's closer to 7 or 8 years. And for older folks, maybe over age 65, the average survival time after a lung transplant is about 4 or maybe 5 years. But again, it's an average. It means half of people do better than that. And overall, if you make it through the first year, and the risk of dying within the first year after a transplant, unfortunately, it's about 8 or 10%. But if you do survive that first year, then 50% of people live longer than 10 years. So it's not 100% of people die in 5 years. I just don't. That's not a good way to look at it. There are people who don't do well early on, and there are people who do well for 1 decade, and even nowadays, 2 decades. We've had people survive more than 20 years after lung transplants. So it's not exactly, it's not as simple as only 5 years. Let's move to myth number 8. I don't know how many of you have heard of the term palliative care, but many people think that when their doctor or nurse practitioner offers them palliative care, it means that they're dying. And that's not true. So palliative care is also called supportive care, and it simply means treating symptoms of a disease. For example, in pulmonary fibrosis, that might mean giving oxygen to treat breathlessness, or treating cough through a different variety of ways, or treating other symptoms like depression and anxiety. But palliative care is not hospice care. Hospice care is given towards the end of life. And I'm going to use this picture, which is from the National Consensus Project for Quality Palliative Care, which is already about 15 years old, but we, as doctors and nurse practitioners, we use this all the time. This is a model of progressive diseases or chronic diseases, including pulmonary fibrosis. And it's actually a timeline, and it starts on the left. So on the left, you can see this disease-modifying therapy. Most of what we do early in the disease is trying to treat the disease and slow it down or reverse it or whatever we can do in that regard. And then as we move to the right, you can see this means progression of the disease, and palliative care here in this dark green becomes more important because symptoms get worse and we focus more and more on treating symptoms. And then hospice care is something that's often initiated in the last few months, the last 6 months of life, and it encompasses treatment of symptoms, but there's much more involved in hospice care as well. And I'd refer you to a few resources on the internet. If you Google or search for palliative care, hospice care, there are some excellent websites that not only give you more information about them, but can direct you to forms such as physician order for life-sustaining therapy or medical order for life-sustaining therapy, and living wills and healthcare proxy forms, etc., that may be of great value to you. And then bereavement, which of course occurs on the side of the family after someone has passed away, is also considered part of this continuum in providing support for the bereaved. So palliative care, again, can even be initiated early on in the course of the disease. It simply is treating symptoms. Now we have 2 myths left. The first one, or the second to last one, I guess, is about stem cells. And there's a myth that stem cells can treat pulmonary fibrosis. So I want to make a clarification. There's a medical treatment called the stem cell transplant that I'm going to define on the next slide. And that's completely different from what some people call stem cell therapy. And I've put therapy in quotes because I don't believe it's actually a therapy. There are people who have sought out care by receiving stem cell therapy, usually involving injection of some kind of stem cell into the body. And I want to make it clear that there are no effective stem cell therapies for pulmonary fibrosis, regardless of what you've seen on the internet or heard from others. And when I talk to colleagues of mine around the country, they've told me they've had patients who have sought out stem cell therapies at different places, either in or outside the United States, who have appeared to have had severe complications, and some have died following this quote-unquote therapy. So I tell my patients to not do this. My patients who have gone and done it have not gotten any better from it, as far as I can tell. Again, regardless of the stories you might have seen or heard about. Now, in contrast to stem cell therapy, stem cell transplants are a proven effective treatment for certain medical problems, and this includes certain cancers. It also includes scleroderma, which, as I mentioned, can cause pulmonary fibrosis. Stem cell transplants for scleroderma, I'm not an expert in that, but I believe are predominantly used to treat the skin condition that goes along with scleroderma, which can be very disabling. There's still a lot that we need to learn about whether or not these stem cell transplants for scleroderma help treat the lungs or not. Certainly they're at risk for lung complications from a stem cell transplant, so more to learn about that, I suppose. And then finally, there are research studies of stem cells in pulmonary fibrosis that are encouraging. And if you are interested in participating in a stem cell research study, you can go to the Pulmonary Fibrosis Foundation's clinical trial finder, which you can find a link to at the Pulmonary Fibrosis Foundation website, which is pulmonaryfibrosis.org. I don't know if any of these trials are currently enrolling. I think that they will be, or there will be at least one enrolling in the short term. Very important for you to understand that research studies are free to participate in. That is, you should never be charged to participate in a research study. If you are being charged, it's not research. These studies also must be approved by an institutional review board that involves an informed consent for research. That's a written form that you would read and sign to participate. Just to be very clear, trying to distinguish research from these other quote-unquote therapies that are being offered. And our final myth is that people with pulmonary fibrosis can't exercise. And that's definitely not true. I won't read this slide. I'll leave it up there for you while I speak. But for many people with pulmonary fibrosis, exercise is an important part of their treatment. Usually in my practice, for a patient, when it's appropriate, I will recommend a program called Pulmonary Rehabilitation. This is a structured exercise program done in an outpatient setting, in a physical therapy setting, supervised by physical therapists and usually a doctor, and it's a exercise program where you would engage in aerobic exercise, like walking on a treadmill or using a new step machine or other machine where you're working your large muscles. They monitor oxygen levels on your fingertip, and if needed, they can give you oxygen during exercise if prescribed by your doctor. And over the course of those 8 weeks, they ramp up the exercise regimen, and that allows you to get a little bit more physically fit. It doesn't necessarily treat the lungs, but it helps you so that you can live a healthier, better life. And most people, after they've completed pulmonary rehab, they will be able to get around much easier and be able to function better in their life, have an improved quality in their life. And you can also maintain that exercise regimen afterwards, either at home or in a gym, or sometimes the Pulmonary Rehab Center will let you come back once a week for a maintenance program. You can learn more about it on the PFF's YouTube channel. We have a whole bunch of videos, including one on pulmonary rehab. So it is very important. And in my practice and colleagues I've known, we've all had patients who do what you might think of as remarkable things, wearing oxygen. They run, they play basketball, volleyball, canoeing or kayaking. uh, depending on your physician's guidance and recommendations, it may be safe with oxygen, in many cases, to do those kinds of activities. Many people will use oxygen as a tool to live a healthier and better life. So that's the end of this webinar. I want to thank everyone for participating, Bridget from the ATS and Jen from the PFF. Also want to thank our sponsors, Boehringer Ingelheim and Genentech, and I want to thank all of you for listening, and I hope that you'll join us in September when the PFF holds its next disease education webinar series. Thank you all for attending.
Okay, great. Thank you, Dr. Lederer. We can take questions now, so if you have a question, please type it into the question sign icon box, and I can read it to Dr. Lederer. So we do already have one question. So Dr. Lederer, Rehab asks, on which basis do we choose between antifibrotics, and is there any preference?
Excellent question. So which antifibrotic, how do we choose one antifibrotic versus another? And just to be clear, the antifibrotics are two of the drugs I mentioned earlier. They are pirfenidone, which is also known as Esbriet, and nintedanib, which is also known as Ofev. So there's two ways to think about it. Can we choose one or the other based on which one works better? And can we choose one or the other based on an individual patient's preferences and side effects and medical conditions? So we'll talk about both. So regarding effectiveness, both drugs, when compared to a placebo pill, both drugs seem to work about the same. They both slow the progression by about 50%. So in my opinion, there's really never a reason to choose one over the other based on how effective we expect it to be. Because generally, I expect them to be equally effective. On the other hand, thinking about a patient's preferences and side effects and medical conditions, that often will heavily inform how I choose or recommend one or the other. For example, since a side effect of Ofev is diarrhea, someone who already has some GI problems, for example, who might have irritable bowel syndrome, they may not want Ofev. They may value not having Ofev, and then that would steer us towards Esbriet. On the other hand, someone who might already have upper GI problems and difficulty eating or poor appetite or weight loss, they might prefer not to have Esbriet because it might worsen those problems, and that would steer us towards Ofev. And there are also other reasons. There are some drug interactions, not a lot, some drug interactions, so we're always a little bit cognizant of that. That might steer us one way or the other, not commonly. And then there are medical problems that might steer us one way or another. For example, if you're on blood thinners, then Ofev might not be the right choice. Depending on other medical problems you have, it might steer us towards one drug or the other. So it is an individualized decision. And when I've had this conversation with patients, and I just did this about 2 hours ago, by the end of a conversation about how the drugs are taken and their effectiveness and side effects, most of the time patients have a preference. So it really is important to have an educated patient. There's written material in your doctor's office. If you're seeing a pulmonologist, there's a lot of information on the internet about these drugs. So often, through education and communication, we can find the right drug for the right person. That was a great question.
Zach asks, if you receive a lung transplant, is IPF gone or does it come back?
Ooh, another good question. So the answer is that IPF, when just referring to IPF now, is one specific form of interstitial lung disease. IPF has never been reported to come back in a transplanted lung. And that's probably because, number one, it takes years to develop, I think, but maybe more importantly, the lung that, it was a property of the lung itself that was prone to develop scarring. And the cells are abnormal, or there are certain genes or something else. So it's never recurred. But there are other kinds of interstitial lung disease that have recurred either in very mild ways or sometimes in more severe ways. For example, people who have sarcoidosis and get a transplant will often find little tiny bits of sarcoidosis still in their lungs, but only very rarely would that cause symptoms or any medical problems. So depending on what kind of interstitial lung disease you might have, your doctor can tell you whether or not it might recur. But even the ones that recur, it's not common. It's not common. It's not something we worry a lot about.
Donna asks, do you recommend gastric acid suppression or a bed wedge elevated head for patients with interstitial lung disease?
Oh, so that's a hot question. This is a very interesting area in the field of pulmonary fibrosis right now. Just a few weeks ago, the results of a clinical trial were published, and it was a research study studying whether or not surgery to treat reflux, that is, there's a surgical procedure that will tighten up the connection between the food pipe and the stomach and prevent reflux, whether or not that type of surgery can help people with pulmonary fibrosis, and specifically idiopathic pulmonary fibrosis. And the study was very interesting in that there were some suggestions that it might help, but it wasn't definitive, and it was a small study. There were about 56 or 58 people in the study, I think. Half got the procedure and half did not. And there is a recommendation right now out there to use antacids to treat people with IPF. Now, all of this boils back down to a theory that acid reflux contributes to idiopathic pulmonary fibrosis. Now, I don't think that that's been proven. It's a long-standing theory, got to be 20, 30 years, and there's evidence suggesting that it might be a cause, and there's evidence suggesting that treatment might be helpful. But there's also evidence on the other side. There's some evidence that taking strong antacids, like omeprazole and other drugs that we call proton pump inhibitors, might increase the risk of lung infections or other medical problems, and certainly any surgery can be risky for people with pulmonary fibrosis. Not that you should not undergo surgery if your doctor recommends it, but there may be an increased risk. So it's a very difficult decision. What I would say is the following. Number one, if you suffer from acid reflux, you should talk to your doctor about regardless of whether or not you have pulmonary fibrosis. If you suffer from acid reflux, you should talk to your doctor about whether or not medications might be helpful, whether a wedge in the bed might be helpful, whether blocks under the bed to raise up the head of the bed might be helpful, avoiding certain foods like tomatoes and peppers and chocolate and mint and others. There are many different things that can be done to help manage symptoms of acid reflux. Whether or not patients with IPF should do all of those things and or even have surgery, I think really needs to be tailored to the individual patient. I don't think there's one right answer for everyone. In my practice, as I just said, I tailor it to the individual based on symptoms, based on whether or not reflux, even if it's silent, might be present, and other factors. So I wish I had a single answer for you. Maybe in the next few years we will have a better answer. I hope we do.
Janice asks, do you have patients who take both antifibrotics together?
Yet another good question. There have been now, I think, 2 studies, research studies, looking at using the drugs together, and they haven't been large enough to really make any conclusions about whether or not they're better when you give them together. That is, do they work, additively? Like, does it help even more by taking both? So unfortunately, we don't have a research-based or evidence-based answer for that. I do know that those studies suggest that there may be more side effects. That's not surprising, since both drugs cause side effects in the GI tract. Taking them both might cause more side effects. I do not prescribe both for the same patient in my practice, and I think that insurance companies would probably freak out if we asked them to pay for both drugs, because the insurance companies pay a lot of money for these drugs. So I don't. My hope is that we do figure out a way to use 2 or even 3 medications to treat this disease. That's what we do for many other chronic lung diseases like COPD, pulmonary arterial hypertension, cystic fibrosis. We might use 3 or 4, even 5 different medications sometimes. So I hope we get to that point where we know that it's the right thing to do. But for now, generally the answer is no.
This is our last question, and Donna asks, do you use antifibrotics in patients over 80?
Oh, that's a good question. I do. And I guess that question probably arises in part because older people were excluded from the clinical trials. But I do it on a case-by-case basis. But that's actually true for all of my patients. That is, using these drugs for everyone, every single person, is probably not the right thing. And using it for many people is probably the right thing. And the way to figure out who we should and shouldn't treat, or in my practice, who I should and shouldn't treat, really boils down to that patient. There are some patients where I talk about the drugs and they say, oh, I absolutely don't want any of that, and I respect that. And there are other people who say they want it, and maybe I'm not trying to talk them out of it, but I'm trying to present a balanced view because I'm worried that side effects may be more burdensome than the benefit. And for me, a lot of it boils down not to age, but to how well I think they might tolerate the medication, combined with how severe their disease is. Someone has no symptoms and normal lung function and the earliest disease possible. We could put them on medication, but how much is that really going to help in the short term? And on the other extreme, people who have more advanced disease, it may just cause side effects without really helping someone in the last months of life. I don't know. We don't actually know if it would help people who are very, very ill. But it's a conversation I have with every patient, and we figure it out.
Okay, great. That's all the questions we had for today. I just want to thank you so much, Dr. Lederer, for this informative webinar, and thank you to Jennifer Mefford from the PF Foundation for helping us organize this. And have a wonderful day, everyone.